Thank you very much for the kind invitation to come and speak to you. This probably will be the shortest talk of the day, and I'm going to talk about the Clostridium Difficile infection objectives. He says, trying to get these to work. They're the same as last year and the year before. Thank you very much. Okay. So why is Cdiff still an important issue that every year, despite everyone saying, get rid of the objectives, we don't need them anymore, the reason we still have them is because there are still over 2,000 deaths a year from Cdiff. It's important. And on the graph on the left-hand side, the solid line is actually deaths from Cdiff, and you can see it still sits above Staph aureus bacteremias, but certainly probably half as much as E. coli bacteremias, but it's still a really important sort of element that we've got here. And if you look at the graph on the right-hand side, which is looking at the 30-day all-cause fatality rate by age group, you can still see the mortality, certainly in the over 75s, is really high. And it's probably similar like having a fractured hip. It causes that rapid decline. And I know one of the studies I was involved in, that by the time you get to 90 days, 1 in 3 patients have actually died. And I think that's very sad, and that's why it's still really important. So a bit of background. So there will always be C. diff infections. Whatever happens, we will always sort of have them. You find it everywhere in the environments, in the soil, water supply, and be carried asymptomatically, with levels potentially up to 7% general population. And C. diff infections will occur outside of the healthcare environment under the right conditions. And I'll show you some information at the end about us trying to understand a bit more. And one of the things that we've tried to look at is actually to try and understand a bit more about where the onset of C. diff infection is coming to, and really to try and understand what interventions we can have, and I'll explore this a bit later. So the role of NHS improvement is to publish C. diff objectives for acute trust and CCGs every year. It's calculated on the basis of requiring continual improvement, and it also reflects that those with higher rates have to do more than those with lower rates, and it gives commissioners the opportunity to exercise a degree of discretion where there have actually been breaches in care, and I'll talk about this again in a few slides. But they can also take into account under specific circumstances whether the sanctions are appropriate or not. So what about the history of C. diff? I'm not sure how many of you are old and grey like me, but certainly my grey hair gives away that I was probably firmly working in the NHS back in sort of 2008, when the Daily Mail first started reporting on this new superbug killing 1 patient in British hospitals every hour, and it was a scandal. And then Panorama doing how safe are your sort of hospitals, and I think that really sort of focused the government at the time into do something. And then you can see over the subsequent years, by actually using fines where you exceeded your C. diff objective, so £50,000 fine per CDI over your preset objective, really drove down the numbers of cases they were. And you can see since 2008 there was actually a decrease by 74% on there. But still the bulk of these, 80%, were actually hospital onset and healthcare associated. So in April 2014, trusts were actually asked to see if any of the C. diff infections were actually linked with a lapse in care, and there was a checklist that was actually developed to sort of help. And only cases associated with a lapse in care should be included for inclusion calculations. And the reason the changes were made, because even though we'd seen year-on-year decline, we'd actually sort of slowed, and it was thought that some organisation had probably reached this irreducible sort of level, and that's why the new guidance came up. So this is how they set the objectives, and you can see it was split into non-teaching acute trusts, teaching acute trusts, and CCGs. And then you can see, depending on what your C. diff rate was currently compared to sort of previously, you were set a certain reduction. And there has been a little bit of gaming that's been going on by people saying, I suddenly want to be classed as a teaching hospital rather than something else to allow their allowances. The rules are set up fairly firmly. The NHS England has a list of institutions which are classed as teaching hospitals and those which aren't. So if you think you can suddenly switch, try again. And so the other advantage of this is instead of having a fining system on the 50k per case you were over, it was potentially going down to 10k. And actually it was an encouragement to try and invest, if any fines were done, into things that would improve the care of patients. So this is a lapse in care sort of checklist, and I'm sure you've all seen it. It focused on looking at diarrhea on admission, if there are risk factors, if you were using the right stool chart or isolation, whether you were following sampling guidance, whether the patient had been looked after for 3 months sort of prior, if they'd had Cdiff before and it was a recurrence, were they initially treated correctly, were other contributory factors being sort of looked at, proton pump inhibitors, enteral feeding, looking at antibiotic therapy for the last 3 months, were they following guidelines, were they de-escalating on results, then looking at the treatment of Cdiff, was it following the guidelines? So if it was severe, were you actually using your guidance for the treatment of severe cases? And then what the outcome was at 30 days. And actually, was the patient informed and actually did they understand? Then there were elements looking at environmental issues such as hand hygiene score, cleaning scores, whether deep cleans have been done, organisational issues looking at staffing, training, communication, documentation, and then to see whether diarrhea optimisation was actually occurring within this sort of the organisation. And actually, had there been lessons learned, were there recurring themes that were sort of coming out, and its preventability. So that seems fairly sort of comprehensive. So what was happening in practice? So this is some data from London, which Sally Kingsland from NHS England in London got from doing a questionnaire of all London CCGs. And they got responses from 16 acute trusts, and nearly all of the CCGs within sort of London. And 60% of the acute trusts reported Cdiff numbers above the threshold that they'd actually been set. So out of the 671 Cdiff cases recorded across the 16 acute sort of trusts, only 14% were agreed as actually having a lapse in care, with a range of 0 to 50%. And I'm staggered. I know within the Leeds hospitals, we have probably half hours probably have a lapse in care of some sort or another. So there's not sort of standardisation that exists. And staggeringly, 37% had actually had agreement there were no lapses in care at all, which I personally don't believe. And none of the trusts had actually imposed financial penalties. And then one CCG report they hadn't followed the lapse in care sort of process, despite their local trust being above the threshold. Okay, so the CCGs were asked also about community Cdiff cases. And you can see sort of on here, out of the 26 CCGs that responded sort of in there, you can see only 2 of them looked at cases related to serious instances, 5 related to community inpatient facilities, 6 said they had no process in place, 1 said they weren't notified of any cases, 2 said they had information governance problems, 2 said they had a comprehensive process, and 2 were gathering broader insights on how to sort of deal with this. So how are we doing? Well, in 2014-15, when we brought in sort of the guidance in there, not surprisingly, we saw an increase in Cdiff, because I think there was a get-out-of-jail card that was actually being introduced here. Plus, the flu vaccination didn't work quite as well that particular sort of year. And what we saw in primary care was increase in amoxicillin prescriptions. We also saw in hospitals amoxicillin co-amoxiclav prescriptions increasing, and we also saw the Cdiff. And you probably can't see it because it's all PHE blue, but it's sort of the line that looks like it's slightly going up in that October, December to January, March element sort of on there. So the following year, we saw really no change taking sort of place sort of overall, But the year that's just ended, we actually saw a 9% decrease, and that was 11% decrease in trust based on a rate, and non-trust 8.5% based on numbers. And because we hadn't seen a big change, we kept the Cdiff objectives the same. Having problems with my button here. However, when you look at the rates of Cdiff and you look at NHS offices, you can see a very clear north-south divide, and the north clearly has far more cases of Cdiff than the south does, and that is almost the reverse we're seeing with MRSA, E. coli. So, why have Cdiff infection cases dropped? This is not proven, but I think this is some of my own personal thoughts about this, because I don't think we've changed very much else at all on here. And I think one of the reasons we've probably seen a change is the clinical improvement schemes that have been targeting on reducing total and broad spectrum antibiotic use have probably had an impact. Certainly we've seen the in-quality premium, we've seen broad spectrum antibiotic usage decrease by 10% last year, it increased by almost 7% the year before, and then total antibiotic use over a 2-year period is down by 7%, and it's remained down. So we're using less antibiotics, certainly in primary care. And then in the hospitals, we've seen this 8% reduction in piptazo and in carbapenems. And I think that's had an impact on what we've been seeing. So as I mentioned earlier in the talk, one of the things that we're really trying to understand on here is we know that probably around 80% of Cdiff cases have actually had some involvement with their local hospital on here. And there's a bit of work going on at the moment by Public Health England trying to understand where the C. diff has come from, whether it's actually healthcare onset and healthcare associated, so that's within that first bit before the patient is actually discharged from hospital, whether it's community onset but it's been within the 4 weeks since they were discharged from hospital, whether it's community onset but it's indeterminate association in that it's that that 8-week period, so from weeks 4 to weeks 12 after discharge from hospital, and then finally after 3 months, which is probably community associated, community onset. And if you look around on the graph and the data from 2015, 16 back to 2007-8 on there, you can see the community onset, community associated has been slowly growing. So I think there's a bit more work probably we need to do in the community. But you can see the bulk of it still has something to do with hospitals. And I think anything we can do to try and keep patients out of hospital can only be a good thing. So in summary then, the objectives are set at the beginning. They've been the same for the last 3 years. We've seen big improvement, 77% reduction in CDI, even though it did plateau temporarily for a 2-year period. I think the clinical improvement schemes to reduce antibiotic usage probably have had an impact on C. diff reductions, and certainly had a big impact on the use of broad spectrum antibiotics. We've seen this large drop, 84% drop in hospital onset C. diff, and a slightly slower reduction in the community side. There's enormous variation in the Lapse care implementation, and I do almost implore those commissioners out there to really try and get more learning from this opportunity. And I think we need a collaborative review model that allows that better learning to take place and hopefully get a more consistent approach. And I think the future is certainly a local antimicrobial resistant approach across that whole health economy. And if you aren't looking at the Public Health England AMR Fingertips portal yet, please go away because it contains all that information to help guide you. Thank you very much.